Good afternoon and welcome to the 2022 Carole Samuelson Endowed Lectureship in Public Health Practice. I'm Paul Irwin, Dean of the School of Public Health, and I'm honored to welcome you to our lectureship today. Let me tell you a little bit about the lectureship and a little bit about Dr. Samuelson. The Carole W. Samuelson Endowed Lectureship in Public Health Practice was established in 2002 at the UAB School of Public Health by family, friends, and colleagues to recognize her courage, tenacity, and leadership in promoting quality health and educational services to the public. Dr. Samuelson was born in 1941 near Greenville, North Carolina, and died February 14, 2009. She was a pediatrician and Jefferson County health officer from 1985 until her retirement in 2002. She was a 1968 graduate of the University of North Carolina School of Medicine in Chapel Hill and completed her residency in pediatrics at Strong Memorial Hospital in Rochester, New York. Dr. Samuelson joined the Jefferson County Health Department in 1975 as a part-time clinician. Within 3 years, she was directing both of the county's primary care clinics. She was promoted to director of the primary care department and then to administrator of the entire health department in 1985. This endowed lectureship honors Dr. Samuelson for her outstanding service through years of devoted commitment to the Jefferson County Department of Health, as well as many other community and statewide organizations interested in providing quality health care. Throughout her professional and community activities, Dr. Samuelson led with diligence and innovation while always placing the public first. This lectureship was created to honor her passion for excellence, as well as to continue her tradition of intellectual innovation and community involvement. We are honored today to have Dr. Paul Samuelson, her husband, join us for this lectureship. Paul, good to see you again. Before I introduce our speaker, let me thank Corey and Chris and Sarah for all you have done to make this happen, all the logistics, the food, the room setup. Thank you very much. Now to introduce our speaker today. Dr. Lisa Koonin is a retired employee of the Centers for Disease Control and Prevention, the CDC, founder of Health Preparedness Partners, LLC, and adjunct assistant professor of health policy and management at the University of North Carolina Gillings School of Global Public Health. Prior to founding Health Preparedness Partners, LLC, Dr. Koonin served in several leadership positions over 30 years at the CDC. During that time, she led the development of a national preparedness plans and policies, led and conducted large format exercises, and consulted with businesses, state and local governments, healthcare facilities, non-governmental organizations, academia, ministries of health around the world to improve emergency preparedness. She served as a leader in multiple national and international health emergency responses while at the CDC, including the 2005 Marburg virus outbreak in Africa, 2005 Hurricanes Katrina, Rita, and Wilma, the 2009-2010 H1N1 influenza pandemic, the 2013 H7N9 avian influenza outbreak in China, the 2014-15 Ebola response, and the 2016 Zika response. In 2019, she founded Health Preparedness Partners, LLC, with a goal of helping businesses, health departments, healthcare facilities, and other organizations prepare for health emergencies to protect their organizations, workforce, customers, and communities. Dr. Koonin is a frequent lecturer at national and international conferences on pandemic and infectious disease preparedness and response, and has published more than 90 peer-reviewed scientific publications on an array of public health and preparedness topics. Dr. Koonin has experience as a family nurse practitioner and epidemiologist. She earned her Master of Nursing and Master of Public Health degrees from Emory University, as well as a doctorate in public health from UNC Chapel Hill. Recently, she was prominently featured in Michael Lewis's 2001 New York Times best-selling book, The Premonition, A Pandemic Story. Please join me in welcoming Dr. Lisa Koonin to UAB.
Thank you so much, and thank you for coming today. I'm very pleased to be here. I want to especially thank Dean Irwin, Dr. Paul Samuelson, and the Broad Street Committee for inviting me and for giving me this honor. I have had such a great meetings with faculty and with the students this morning, warm welcomes and super great discussions. I really thank you for that. I want to first start by saying how honored I am to receive this award that recognizes such an important public health leader, Dr. Samuelson. I'm so pleased to share my experiences with you today in recognition of Dr. Samuelson's passion, courage, and tenacity for public health practice. It's quite an honor to be given this award. What I'd like to do is talk to you today about an evolution in thinking, a series of stories about how I came about recognizing the value of public health and private sector partnerships in improving health. And I hope by sharing these stories, you'll get some inspiration for your own practice. So when I first started CDC, I had practiced for 10 years clinically, and my focus was reproductive health. I came to CDC at the Division of Reproductive Health and was tasked with monitoring surveillance of reproductive events across the country and also trying to solve some of the thorny problems that we faced. And one was preventing unintended pregnancies. We had seen that the level of unintended pregnancies had declined slightly, and then in early 2000s started to rise again. So it was my instinct to start to talk to medical groups and provider groups about what they could do to screen and prevent unintended pregnancies. And actually, I was kind of shocked when they told me that a good part of the decision-making that they had about what services to deliver was dictated by who paid for those services and the health benefits that were available to people. Now, I know this is not a big revelation at this point in time, but back in 2001, when managed care was just starting, it was quite a different way of thinking. And up until then, I think a lot of my colleagues kind of thought that private sector was the evil empire, the dark side. And I became curious to say, you know, I recognize that public health by themselves could not solve every health problem and dilemma that was out there. And could we partner with private sector in any way to improve health? And so I switched from being in the Division of Reproductive Health, and they created a position of partnerships for me where I started trying to learn about how we can improve health through partnerships with private sector. And in doing so, I started thinking about creating a model to guide our work. And what ways did private sector partners affect health? And so this concentric circle model that I'm going to show you tries to describe in simple terms about that thinking. So first of all, private sector affects health by the products and services that they deliver, whether they deliver healthcare or other products or services, either directly or indirectly. Private sector definitely affects healthcare, and most healthcare is in the private sector. The next sort of tier or layer was healthcare purchasing. Today, about 57% of adults who are under the age of 65 get their health benefits through their own employment or as a beneficiary of someone else's employment. So employers and businesses have a very strong role in selecting what services they're going to pay for, and therefore the opportunity to embed preventive services in their selection. Of course, the work site is a huge influence in health. Most of us spend most of our waking hours at the work site rather than other places. And the health and safety of the work site, as well as services, programs, and messaging available at the work site, influences health. And because people are part of families, they can take home information they learn at work or programs that the employer offers to families to be able to be shared at home. And this is really important during emergencies. When there's so much information out there, people don't know who to trust or what to think. Oftentimes, employer messages can help employees and their families as well. And then the outer ring of this model is the community. We know that businesses are stakeholders in their communities. They care about their communities. Their workforce comes from the community. In normal times, without an emergency, we know that employers can enjoin their workforce with community resources like quit lines or health fairs or other kinds of community offerings to improve health. And then during emergencies, the employers have very large roles in terms of embracing public health practice, public health recommendations to make sure that their employees are safe during an emergency. So I used this model, I created this model in the early 2000s and used it sort of to test these ideas and see if we could make progress in public health for improving health by these partnerships. And one of the first things that happened after the model was created was Hurricanes Rita, Katrina, and Wilma. I was detailed to the CDC Emergency Operations Center. At that time, it was in the sub basement where the animals that were in prior years used for experiments were kept. They weren't there anymore, but let me tell you, this was kind of a weird place. And one of the things we started was a partners desk, a place where private sector could reach to CDC and ask questions. And we got amazing information and questions from private sector partners. In the picture, you'll see just some examples of big box stores that were actually on the ground with resources and supplies before government resources arrived. So we really started getting a sense of private sector's role in emergency response just from that hurricane scenario. As I said before, employers are important purchasers of health care, and their purchasing decisions affect what is delivered. So mid-2000s, we had a group of people that worked together at CDC and reached out to the National Business Group on Health. This is a nonprofit organization of Fortune 500 companies that come together to talk about health benefits and improve health for their employees. And we started talking to them about decisions that they had to make when they bought health care and the importance of preventive services. And what they said to us was, how do we know what's important? How do we know what to purchase? How do we know what the evidence is that supports decisions about prevention? And so we pulled together this clinical guide for preventive services from staff all over CDC, infectious disease, immunizations, chronic disease, injury prevention, and put together the evidence and the cost effectiveness of purchasing certain preventive services. In the mid-2000s, we also heard about an avian flu, a bird flu outbreak in China and Indonesia. We had staff in that part of the world, and they were regularly reporting back to CDC about human cases of bird flu. Now, it didn't happen very often, but when a person did catch bird flu, it could be very serious. The mortality rate was extremely high. It was 60%. And our experts at flu at that time were worried that this bird flu virus could jump to human populations and spark a worldwide pandemic. So we started thinking about what was going to be needed to react to a bird flu pandemic. And at that time, the director of the CDC, Dr. Julie Gerberding, came to me and my team. She knew we were working with private sector and said that U.S. companies had been calling CDC and asking for guidance and assistance in preparing just in case an avian flu pandemic sparked. So in response to that request, we created the CDC Business Pandemic Influenza Planning Checklist, which included 6 parameters for businesses to use in planning for a pandemic. And we published that at the end of December in 2005. Now, along the same time, then President Bush was reading John Barry's book called The Great Influenza. How many of you have read that book or seen that book? Well, it's a little bit of a slog getting through it, but it's a really important book because it really describes how severe 1918 pandemic was, who it affected, and how it affected the population. And remember, President Bush had already had to deal with 9/11 and with the anthrax attacks. And he was quite concerned about the prospect of this avian flu or this bird flu jumping to become a pandemic. So he asked his White House staff, what's our plan for a pandemic? And at that time, the thinking was pretty nascent. So the staff immediately began to generate a plan. And a plan came out in 2005, the National Strategy for Pandemic Influenza. And in that plan were specific roles for different aspects of society. And in particular, outlined the importance that businesses played in responding to a pandemic, to protect the health of the workforce, to keep businesses operational, particularly critical infrastructure. In this country, 80 to 85% of critical infrastructure businesses are in the private sector. And also to assure functioning of communities. So businesses were highly outlined in this overarching plan. The next step for this White House team, which was led by Rajiv Venkaya and staffed with Dr. Richard Hatchett and Dr. Carter Metcher, was to develop a specific implementation plan for the federal government to begin discrete planning for a pandemic. And this was going to be an effort that every federal agency was going to undertake. Primarily CDC and HHS had the lead roles, but there were roles for all of the federal agencies. And in that plan, there were 9 chapters. One of the chapters was Chapter 9, and Chapter 9 described the planning that businesses needed to do to protect their continuity and to protect their workforce. And the White House team had heard about the business checklist that our team had produced and somehow got on the telephone with me and asked me if I would review Chapter 9 that they had drafted. Well, it wasn't that good, actually. In fact, Dr. Metcher said that I redlined everything except the title, but helped them rewrite that chapter. And after doing so, they invited me to do some thinking with them about another chapter that they needed to write, which was Chapter 6, Protecting Human Health. And the key question here was, what strategies could we use to protect people and communities until a broadly effective, well-matched vaccine was available? Because we knew when a pandemic virus emerged, that we would not have a well-matched vaccine instantly. We'd have to use the virus to make the vaccine. And at that time, vaccines for influenza were produced growing in eggs. So it was a long process. This was a really important question. And CDC was very interested in partnering with this group to do this. And I was the person that played one of the roles. Here were the questions. What would work to slow down disease transmission and save lives after a pandemic virus emerges, but before we have a well-matched vaccine? Well, we had a limited supply of Tamiflu, oseltamivir, which is an influenza antiviral medicine, and we knew that if we gave it to people every day, it could prevent them from getting the flu. But how could you give an antiviral medicine to 297 million people at the time every day? And there were side effects from that medicine as well. And we certainly didn't have enough to do that. Then we thought about antiviral treatment. Well, antiviral treatment is important, but it doesn't prevent you from getting sick. It treats you once you are sick. So what else would work? And what could history teach us about this issue? So we first set a goal of the work that we were going to do. And you've probably heard this many times during COVID, flatten the curve. And this was the aspiration of our work, which is push off the outbreak peak into the future, decompress that epi-curve, and so fewer people are affected and hospitals and healthcare systems are not so surged. And so what we were looking at is an unmitigated pandemic represented by the dark purple curve and a mitigated pandemic represented by the lower curve. And so our aim was to find strategies that would help us get from that dark purple curve to the other one. So what were our inputs for guidance? Well, we had plenty of epidemiology and studies on flu transmission. If we thought the next pandemic was going to be a bird flu, then it might transmit and behave like seasonal flu. So we had lots of information about that. We also had data and experience from previous pandemics. There had been 3 previous pandemics in the last 100 years at that time. There had been the 1918 pandemic, which was very severe, the 1957 pandemic, which was moderate, and then the 1968 pandemic, which was mild in its effect. And because we saw the effect that bird flu had on the population, we expected the next pandemic was going to be severe. So we wanted to look at 1918 to see what we could learn with what they did to mitigate the pandemic. And since we had such little information, we engaged mathematical modelers to help us create scenarios and do what-if questions about using different mitigation strategies. And finally, stakeholder engagement. And this was reinforced every step of the way by our public health partners and by our CDC leaders, which was we needed to develop a strategy that was practical and acceptable to federal, state, and local public health leaders, like we have the leader of Jefferson County Health Department with us today, public themselves, because they were going to have to implement the strategy, schools, healthcare providers, employers, and other key stakeholders. So this was our job, and a very steep mountain to climb, let me tell you. So first of all, we started looking at the 1918 pandemic. Now, there was no modern medicine back then. We didn't have antivirals, antibiotics, IV fluids, ICUs, and none of what we have today in modern medicine. But what they did have was the tried and true public health measures. They looked at non-pharmaceutical measures like social distancing and closure of schools and other institutions as the primary way that they controlled the pandemic, and also keeping sick people at home. And we found when we looked back at the 1918 pandemic that some cities did a lot better than others. And what was the difference? It was the same virus. It happened at the same time. What did those cities do that made the difference? And so we started to embark on a discovery process. We had heard that Philadelphia and St. Louis were 2 exemplary examples. And Philadelphia had been singled out as being particularly hard hit during 1918. So let me tell you the story about Philadelphia. Some of the first pandemic virus introduced in the country came in the barracks of Boston's Navy Pier. And this was about end of August of 1918. As soldiers and sailors were coming back from the war, and we were fighting World War I during that time, they brought the pandemic virus with them. On August 27th, 2 sailors reported to sick bay with influenza. And 2 days later, 58 sailors were admitted to the hospital. By the beginning of September, it had spread beyond the barracks, and civilians were now becoming ill. Now, September 7th, 300 sailors from Boston arrived in Philadelphia because we were moving the personnel around for training, for commissioning and decommissioning. And so this was the outbreak that in Philadelphia, this is how it started. The first cases appeared shortly after those sailors arrived. Soon it spread to the community. Now remember again, we were in the midst of World War I, and everyone's patriotic duty at that time was to support the war effort. The way they were doing it was raising funds by having Liberty Loan rallies and parades. And city officials had planned a Liberty Loan parade for September 28th in Philadelphia. Well, the public health officials were aware of this outbreak of flu in Philadelphia and warned the mayor, well, maybe it's not a good idea to have such a big public outreach during this pandemic. They didn't even know it was a pandemic, during this outbreak. But it was refused because that would be unpatriotic to not have the Liberty Loan Parade. So on September 28th, you can see the picture that was taken. Tens of thousands of people were gathered to watch that parade for hours and hours along the streets of Philadelphia. Now we know today that one of the best ways of controlling a pandemic is keeping sick people and well people apart in space. We call it social distancing. This is not social distancing. And in fact, within 5 days after this parade, every hospital in Philadelphia was filled to capacity. They stood up emergency hospitals, and they too were filled. And this pandemic almost brought Philadelphia to its knees, with tens of thousands of people becoming ill and hundreds of people dying. When we look at this chart, the blue sharp line kind of looks like that purple curve that I showed you before, the unmitigated pandemic. This is what the epi curve looked like in Philadelphia. Now, in contrast, St. Louis did something very different, and they're depicted by the red curve. So the health officials in St. Louis recognized what was going on the East Coast, and when their first cases came to St. Louis, they shut everything down. Schools, healthcare, faith-based facilities, even the saloons, which was always the last thing to close, the pool halls, everything was shut down. And you can see by looking at the red line there that very few cases emerged. Now, right before Thanksgiving, they thought, you know, we're doing pretty well. The holidays are coming up. Let's lift up with some of our closures. And you can see that uptick in cases, and they promptly reinstated their non-pharmaceutical measures, and the cases started going down. So it wasn't that Philadelphia didn't do anything. They did, but they did it late. They started closures near the peak of that curve. And in contrast, St. Louis did it so early that they blunted the transmission in the city. This gave us a lot of inspiration about what could possibly work. The next endeavor was also thinking about what strategies these cities used. They didn't use just one thing. They used multiple strategies. And what we found was that cities that used multiple strategies simultaneously had 50% of the death rate than other cities. And that was quite remarkable. So we started thinking about layered solutions. In other words, there's no silver bullet. One solution, even our best vaccine, can't by itself control a transmission of a pandemic. To have the optimal response, we needed to layer things together. And so when we were talking about this, we used the analogy of Swiss cheese. That one slice of Swiss cheese had lots of holes in it, but as you layered one slice on top of the other, the solid places in one slice blocked the holes in the slice below. Now, this was borrowed from an economist who had come up with this idea years ago, but we leveraged it as a talking point to explain how important it was to use layered strategies during a pandemic. The other thing we noticed was it was important to keep people separate in space. And we wanted to understand what was the spacing in communities. We were startled to find that children in elementary schools had less than 4 feet of space around them in typical classroom settings. Hospitals had twice that amount of space, workplaces even more, and the home had the most space. So when we're thinking about our strategy in terms of who should we be targeting and how we should be approaching this, this spacing informed some of our thinking, along with a lot of other research. So our goal was to break the chain of transmission, knowing that whatever we did was not going to confer durable immunity like a vaccine, but if we could slow transmission down well enough, we could preserve life and we could buy some time until we had a well-matched vaccine. So, as I said, we learned about distancing. We learned about timing. If you look at St. Louis and Philadelphia, it was about when they implemented their strategies. Early was better. And early is a problem because early means that you're going to lock things down when things might still appear fairly normal. And so public health leaders are going to get a lot of questions about, why are you doing this now? It's not that bad. And the answer is, if we wait till it's really bad, it's too late. Targeting, meaning looking at populations, and we really realized through our epi studies of influenza in children and the spacing on school buses and schoolrooms that children were clustered close together and that they were very good vectors of disease. How many of you have children? So first week of school, they bring home all these lovely viruses to the house, right? And that was the thinking about this as well. And then layering. And then this allowed us to produce in 2007 our community mitigation strategies. And simply put, these are what they were. For every level of pandemic, mild, moderate, or severe, sick people need to stay home. And then if severity warrants it, meaning if it's not mild, if it's more than that, perhaps people who live with a sick person also need to stay home, trying to interrupt that chain of transmission, social distancing in communities, and school closures. However, not only did we have the conundrum of developing these strategies, but we also had to recognize the partnerships and the stakeholders involved in doing this. You can see on the cover of the strategy that we produced the 14 seals of federal agencies. We had to engage with Department of Homeland Security, Department of Transportation, Department of Labor, Department of Education. All of the federal agencies had to work together to produce this guidance because it just didn't affect health. It affected the whole of society. Here's a picture of us on the steps of the Eisenhower office building. We would meet every other week in Washington and put our heads together about how best to implement this strategy, taking into account stakeholders' input. And the biggest lessons were really about acceptability and feasibility. Not only were federal agencies involved in developing this, but we had to include our state and local partners because they were the ones who were going to implement it on the ground level. And I want to say that the state and local public health folks are heroes and have been in the COVID response, and hats off to them in the audience today. But we also had to talk with schools and school superintendents, healthcare providers, employers and businesses, and then the public about their willingness to use these measures. And context mattered. People were willing to use disruptive measures if the severity warranted it. And what we realized, coming back to the theme of private sector, is that we relied on the private sector for the uptake of this guidance. If employers did not have flexible leave policies, people who were sick had to do the calculus about whether they go to work or whether they stay home. And so we had to do a lot of work educating our private sector partners about the importance of their HR policies and how, if their HR policies aligned with public health, we could reduce transmission of disease and save lives. We also needed to engage the private sector about social distancing and what that might mean at the workplace, and the fact that some businesses may have to temporarily close. All of this is precursor work that came about, as you saw, in 2020 with COVID. So the next thing that happened after 2007, we have our policy, we have our procedures and our guidance, was the 2009 H1N1 pandemic. But that pandemic was not the pandemic we planned for. It was not severe. And although CDC was getting some worrisome reports from Mexico initially, once the epidemiology was known, we recognized that it wasn't as severe as we thought. And sick people staying home was the cardinal guidance during that time. We also rolled out H1N1 vaccine during that pandemic, but it was slow going. Like I said, back then, vaccine was grown in eggs, and the government has sort of overestimated how fast that vaccine could be made. There were some delays, and right when we were having a peak of illness in October of 2009, we did not have much vaccine at all. And so the incident manager of CDC's response came to me in early December and said, we're in a period of transition. And you can see as the decline in cases, but there's a big uptick in vaccine availability. That's the blue line. And he said, we're going to have a lot of vaccine, and we're going to have it in the next couple of weeks. But the Christmas holidays are coming. Doctors' offices and public health clinics are going to be closed. How can people get vaccine? Do we think we can work with other entities to help us? And pharmacies were mentioned as an important partner in this effort. So I spent the whole weekend working with others at CDC, calling the largest pharmacy chains in the country and asking them if we could send them a large volume of vaccine. Would they distribute it to their pharmacies, and would their pharmacists administer it? That year, in 2009, every state had granted pharmacists the ability to give flu vaccine to adults if they were trained. And so we knew we had the backbone, we had the ability to do this, we just needed the willingness. And so we got 10 large pharmacies to agree to take 100,000 doses each of vaccine. And not only did they take the vaccine, distribute the vaccine, administer the vaccine, but they also extended the reach of public health by marketing and advertising about the vaccine. And 5.4 million extra doses were sent out to pharmacies during that time. And we believe many, many more people were immunized at nighttime, on weekends, and during the holidays through the use of pharmacies. And we sent those doses to 15 different sites, and they in turn delivered it to over 10,000 different pharmacies, with reach almost all across the country. So we learned a lot from that effort in partnering with private sector pharmacies. And so going forward, CDC started doing some research and modeling about including pharmacies in our pandemic response going forward. And in this modeling study, they found that by including pharmacists as administrators of pandemic vaccine, that state and local public health could reach their goal of immunizing 80% of the adult population 8 weeks earlier than if we don't include pharmacies. And so that became very compelling, and we started doing outreach through ASTO and NACHO to state and local health departments to encourage them to develop partnerships with pharmacies. And in 2006 and 2007, before the pandemic started, about 7% of adults got their flu vaccine at a pharmacy. And in the most recent year for which we have data, which is 2020, 2021, 39% of adults got their flu vaccine at a pharmacy. And for the first time, more adults received flu vaccine at a pharmacy than any other location. And so pharmacies were the backbone of COVID vaccine distribution. We built on that experience. Over 270 million doses have been delivered by pharmacies, with 3 out of every 4 booster doses delivered by pharmacies. So we learned quite a lot about leveraging the reach, the convenience, and the accessibility of pharmacies to do this work. So coming back to social distancing, I just want to tell you that I was watching the news one night, I think it was early March of 2020, and Lester Holt, who's one of the news anchors on NBC, was talking about the pandemic, and he mentioned the words social distancing. Now, I had never heard anybody else, other than our little small group who'd been doing planning back in 2007, mention that term, and my head like snapped around. It was almost like he said my name on TV. So I said to my husband, "Did you hear what he said? Social distancing." And so these strategies were starting to get unfurled. Now, we were very new at this. I mean, was it 6 feet apart? Was it 2 dogs apart? I mean, there was a lot of uncertainty about how to really do this. But we were using the tool that we had learned about and that we had promulgated. And a New York Times reporter picked this story up and published an article called The Untold Story of the Birth of Social Distancing, and featured the work that Drs. Metcher, Hatchett, and I, and others had done in producing this guidance. And on the heels of that, as Dean mentioned, Michael Lewis prepared the premonition and included some of that story in that book. And I think that's why I'm here today, actually. So, in summary, the private sector has been an incredibly valuable partner in the COVID response. They've been responsible for vaccine manufacturing and testing, vaccine administration, alignment with social distancing, masking, and hand hygiene guidance, improved sick leave policies so that people who are sick can stay home without penalty. Now, we haven't gotten to 100% yet, and there's still a large proportion of people who don't have these benefits, but progress was made. An increased flexibility to work from home. That virtual working environment really sustained a lot of work when we were on the stay-at-home orders, but not everybody can stay at home and work. If I'm a nurse, I can't provide patient care from my living room. So there are a lot of people who couldn't stay at home. And then support for those critical infrastructure workers. Private business also suffered during the COVID-19. There was a lot of business closures, layoffs, and pushback on public health guidance. But progress was made. And I think public health partners really understand how important it is to wrap arms and link arms with private sector during an emergency response. So where are we now? The pandemic's not over. And our public health system very much needs resources and support to respond to the constant array of emergencies that are faced, including the results of chronic or sporadic funding, erosion in the workforce, outdated systems and technology, and inconsistent political support. We need a whole of community preparedness and response approach in order to best respond to an emergency. And the private sector are critical partners. I'm encouraging us to consider leveraging their existing strengths and their reach to the population to improve a pandemic response. So the call to action. If we can link arms with private sector, not only prepare for emergencies, but also address community health improvement and reducing inequities in healthcare right now, then when an emergency is declared, we have a ready workforce that we can work together with. We can recover together and we can gather those lessons learned so that we can plan for the next event and the cycle can continue of improvement. I believe that private sector partners are integral to community emergency response, and I encourage you to think about including private sector partners in the work that you do. Thank you very much.